Dr. Avnindra Gupta, our chief instructor for this course. Dr. Avnindra Gupta is a senior vitreoretina surgeon with us at Center for Sight and also an entrepreneur of Surgeon Power Excellence at Nayan Jyoti Eye Center in Faridabad. Sir has been one of the major mentors for all VR surgeons in Center for Sight who have shifted to this glue diode technique. And through this presentation, I know he will take you through certain very complicated situations wherein he has used the kind of feasibility of this technique along with his surgical skills to pass through some very tough scenarios. Over to you, Dr. Gupta, please.
Uh, Thank you, Ritesh. What I'll be talking is glued IUL in complicated situations. And along with this, I'll be talking about showing some videos of complications. So if you have situations like this, ACIUL or a dislocated IUL in the vitreous cavity, a corneal scar with an absorbed cataract, uh, pseudophakic bullous keratopathy with an ACIUL or aniridia. The main problem is, should we leave this eye aphakic or rehabilitate this patient with good SFIUL? Because most of this patient, the other eye is good. And if you don't implant the eye in these patients with the IUL in these patients, then the eye will not be functional. This is one of the patients you can see underwent complicated cataract surgery with sector iodectomy. ACIUL was placed, and this patient was a doctor, and you must not have seen any time a dislocation of an ACIUL. And because of this dislocation, the patient also had CME. You can see the fluid and intraretinal cyst in this patient. So we went ahead and did a surgery. We created a flap nasally and temporally, and we did a total vitrectomy. All the vitreous was freed from the IUL, and this haptic was held with a 23 gauge forceps and was brought into the pupillary plane. With gentle maneuver with another forceps, the haptic was held and is gently externalized. Once the haptic of the AC IUL is externalized, the IUL is gently rotated. It should not be a very jerky removal because the PMA IUL can damage the endothelium and you can land up within a problematic situation. Once the and you can see I am holding the tip of the haptic, what everyone has told in this course, that catching the tip of the haptic is important. Otherwise, you will land up with kinking of the haptic or a broken haptic. The haptic is internalized. Other haptic is also externalized. A Charrier tunnel is created with the help of a 26 gauge needle, and then this haptic is internalized mm, in the Charrier tunnel. And you can see the post-operative picture, a well-centered IUL. And the important thing, what I was mentioning, or what Rajesh or Dr. Venkatesh was telling us, because of low endophacodonosis, you can see that CME has regressed from before, and this patient improved to 618 vision. Uh, the problem with the sutured scleral fixated IUL and with iris claw lenses is there's a lot of pseudophacodonosis. And if you have a lot of pseudophacodonosis, the incidence of cystoid macular edema becomes as high as 33%. So that's why sutured scleral fixated IUL was not very pretty common in early days. But once as scleral fixated IUL has come, everyone has devised his own technique like Yamane's or Exnic technique or Rajesh technique or glued IOL technique to do an scleral fixated IOL. Basically, the aim of the technique is to fix the haptic into the scleral pocket, which makes the lens absolutely rock stable. There's another patient, 12 years old male, a young male, had perforating injury which was sutured locally. Vision was hand movement, had corneal scar, peripheral antiacenekia, partially absorbed cataract, cataract with occlusio pupillae. We did a ultrasound which showed a normal posterior segment. And we started this surgery. We placed an AC maintainer because putting an cannula was difficult, and we made an introduced in trocar cannula on the temporal side, and we started cutting or removing this partially absorbed cataract. At this stage, we realized that the adhesions are pretty strong, and this cannot be managed with the help of a cutter. So I made a clear corneal tunnel and went with an Vanas forceps and cut the peripheral, cut the leucoma adherents. Along with that, I did sphincterotomies, supranasal, infranasal, and supratemporally. Once this sphincterotomy is done, you can see the pupil size enlarging. You can visualize the posterior segment, and you can do a nice, good vitrectomy in this patient. Vitreous with cortex is removed, and the center portion is cleared. A light pipe is introduced to examine what is the status of the posterior pole, and you can see the posterior pole appears good. So I then decided to go in for an secondary root IOL implant. The lens was injected with the 23 gauge with the injector. The haptics were externalized. Once both the haptics are externalized, it is internalized into the chariot tunnel, and you can see the post-operative picture, a well-centered IOL, and the vision improved to 618. And this is another interesting patient, aphakia with secondary glaucoma, underwent complicated cataract surgery. Surgical wound was from 10 to 2 o'clock position, aphakia with vitreous in AC, secondary glaucoma, uncontrolled on maximal medication, planned for vitrectomy with posterior AGV. And you can see there is a wound here. There is an important thing what you have to understand. This case needs planning. So our glaucoma surgeon said, Dr. Hirsch said, Ki I'll place the valve in the infratemporal quadrant. So he created a peritomy and sutured the valve 8 millimeters behind the limbus. Once the valve was sutured, a 5 into 5 millimeter scleral flaps were created. Once the flaps are created, we created two additional flaps, one in supratemporal quadrant and one in infranasal quadrant, because these were the areas available, and we'll create a corneal tunnel in the supranasal quadrant. The flaps are created, the sclerotomies are made 1.5 millimeters behind the limbus, and we started the vitrectomy. If you want to place the valve in the posterior segment, then you need to do a complete vitrectomy, uh, including removal of the posterior hyaloid. So, if you want to remove the posterior hyaloid and you want to be 100% sure, you have to use tricot. And you can see we are creating an posterior vitreous detachment. And this is the V's ring. All of the vitreous is removed. A total vitrectomy is done. The tricot is removed. Once the total vitrectomy is done, chariot tunnel is made with the help of a 26 gauge needle and a 23 and a foldable IOL is injected. The important thing here is hold the tip of the haptic and don't externalize it, the haptic, until and unless the whole of the IOL is delivered into the anterior chamber. The haptics are externalized, the other haptic is also externalized, and then it is internalized into the chariot tunnel. Once this procedure is done, a fistula is created 2 millimeters behind the limbus, and AGV valve is placed, and you can see the valve coming behind the lens. Because of the exposure of the tube, we also place, now we have started placing a scleral patch graft. Uh, since the iris was injured, we thought we'll also repair the iris. So a CT C6 10 proline was taken, and the iris was enclaved and then docked into the cannula and brought out of the uh, this paracentesis. You can see now three sutures here, 1, 2, and 3. 4 throws are taken, and the 10-0 proline is caught. This is what we call as a sliding knot or a Siepsel's knot. And you can see we have created a pupil. The sutures are cut and the glue is placed over the flaps. And as in all glaucoma patients, the conjunctiva is stitched nicely. And this patient improved to somewhere around 612 vision. This is another patient of aniridia. I wanted to show this patient at what is the anatomical. You can see how well the lens is placed. It's in horizontal position, and an aniridia patient uh, uh, regaining 680 vision. Coming to the complication, if you have an anterior sclerotomy, then you can hit the ciliary processes or the iris root, and you can land up with vitreous hemorrhage. If you have an posterior sclerotomy, uh, you will have less haptic for externalization, and you will land up with unstable IOL and late subluxation. So the tip here is that the sclerotomy should be 1.5 to 2 millimeters behind the limbus. We have learned the hard way around over the years of experience, and I find 1.5 to 2 millimeters. I measure it from the posterior limbus 1.5 millimeter and then make a sclerotomy. Unequal distance of sclerotomy from limbus can lead to IOL tilt and resultant astigmatism. So I always tend to measure the sclerotomy site nasally, nasal and temporal. If you catch the haptic in middle, you can land up with kinking of haptic, what Dr. Ritesh has shown. And if the externalization is too forceful, you can land up with breakage of haptic. And if this haptic breaks, you have to have another IOL. You have to expand this IOL and put another IOL. If you have a loss of haptic, use handshake technique, what Dr. Priya Narang, or you can use Biko technique. And another good technique, what Dr. Venkatesh has shown, you can put silicone uh, stoppers on the tip so the loss of haptics will be prevented. This is one of the patients where I did a glued IOL, and 3 weeks later, patient came with aphakia, and what I realized, the lens has subluxated or dislocated into the vitreous cavity. You can see one of the haptic here, the other haptic is here. So I intend to fix the same IOL into the vitreous cavity. I open the same flaps because it's just 3 weeks old. And the haptic is caught, the other haptic is brought into the pupillary pane. It's sometimes it becomes very difficult to hold this haptic. So what we do is we do an handshake technique, hold the haptic with one forceps, the other haptic is introduced through the paracentesis, and then hold this haptic. The second haptic is also held, and now this time you hold the haptic from the tip. So while externalizing, you won't kink the haptic or break the haptics. So once the haptic is held at the tip, it is externalized. And both the haptics are externalized. You can internalize this haptic. And since there is a dislocation, what I prefer in these cases is I'll put a 10-0 suture for additional stability so that the lens does not dislocate in future. This is another patient. You can see 3 weeks to 4 weeks. You can see there is a melt of the scleral flap, and the haptics are exposed. Once you have a melting, then you this patient can land up with the post-operative endophthalmitis, and this patient also had pain. So we used a sterile patch graft to cover this haptic and prevent the melting. And we sutured this sterile patch graft over the melted uh, scleral flaps. And this patient is now doing good. Many times you will see there is an exposure of the haptic in these kind of situations. You have to just open the conjunctiva and make another tunnel with the help of a 26 gauge needle, or you can use, many of us are now using a 2 millimeter, and this haptic is now internalized into this chariot tunnel, and then conjunctiva is sutured. So coming to the post-operative complications, CME occurs in 5 cases, occurred in 5 cases, RD in 2 cases, scleral melt in 2 cases, dislocation of IOL in 3 cases, choroidal disinsertion in 2 cases. I dealt with expulsive hemorrhage in 1 case, endophthalmitis in 1 case. Incidentally, 2 patients developed macular hole. So to conclude, glued IOL has opened new paradigms in treating and rehabilitating young patients who would have been left aphakic with no useful vision. I'd like to thank Gabor Shariat and Dr. Amar Agarwal, the mentor of glued sterile fixated IOL, for giving this wonderful procedure. Thank you very much.
That was fantastic. Fantastic, Vrinder, showing so many complicated cases, and you're coming out with very good solutions. Just one thing I would like to add here that I've seen, because we do see encounters residents doing, even I have committed a mistake. You were talking about the sclerotomy. I also use between 1.5 to 2 millimeter position. Only thing is that the direction of the entry should be directed towards the center of the globe.
Yeah.
Catches the iris. So that is something which I wanted to.
That's a very good point, Rajesh, you have mentioned. With this